Namaste बेटिया, हमेशा खुश रहो बेटिया. A very good morning to you all. Myself, JV'n Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine, Faculty of Homeopathic Science in JAYOTI VIDYAPEETH Women's University. This is the series of blood disorders, and in the last few lectures we have discussed about anemia. Also discussed about iron deficiency anemia, megaloblastic anemia. We have also started with hemolytic anemias. In the last lecture, we have discussed about sickle cell anemia. In today's lecture, we are going to discuss about thalassemia. Thalassemia is a very important disorder due to which a lot of people are suffering and they have a lot of troubles in their day-to-day lives. So this is a very important topic, not from the examination point of view, but from the practical point of view. Thalassemia is an inherited impairment of hemoglobin production. So there is inherited impairment of the production of hemoglobin in which there is partial or complete failure to synthesize a specific type of globin chain. So this is basically an inherited disorder in which the globin chain of hemoglobin is not able to form properly. Either there is partial or complete failure to synthesize specific type of globin chain. There are two types of thalassemia that are commonly encountered. Number one is alpha-thalassemia and the number two is beta-thalassemia. So we have two types of thalassemias. Thalassemia, we have partial or complete failure to synthesize globin chain. We have alpha-thalassemia, we have beta-thalassemia. And the imbalances of the globin chain causes hemolysis and impair erythropoiesis. So there is impairment of the blood formation, RBC formation, and also there is hemolysis. Great destruction and impaired production. We start first with alpha-thalassemia. In alpha-thalassemia, that is, there is disruption of one or both the alleles on the chromosome 16. So one or both alleles of the chromosome number 16 there is disruption with the production of some or no alpha globin chain. So there is production of either no or some alpha globin chains. There is reduced or absent synthesis of alpha globin chains. In the beta thalassemia, there is reduced or absent synthesis of the beta globin chains. So there is reduced or absent synthesis of the beta globin chain in case of beta thalassemia. So in alpha we have alpha globin chain, and in beta thalassemia we have beta globin chains. In beta thalassemia, there is failure to synthesis beta chains. So it is the most important type of thalassemia. The most common thalassemia that we encounter in our day-to-day practice is the beta thalassemia. It can be of two types. Beta thalassemia can be again of two types, homozygous or heterozygous types. In the homozygous type, that is also known as thalassemia major, it is unable to synthesize hemoglobin A, and they develop with profound hypochromic anemia. So there is development of profound hypochromic anemia and inability to synthesize hemoglobin A. Then next we have heterozygous anemia, that is also known as thalassemia minor. The homozygous one is known as thalassemia major, and the heterozygous one is known as thalassemia minor. It has the complaints of mild anemia and little or no clinical or disability. So major has major symptoms and the minor one has minor symptoms of thalassemia. Now, what are the diagnostic features in case of thalassemia? In case of beta thalassemia major, there is profound hypochromic anemia with severe red cell dysplasia, erythroblastosis, with the absence or gross reduction of the amount of hemoglobin A, raised level of hemoglobin F, that is fetal hemoglobin, and evidence that both the parents have thalassemia minor. So how will you diagnose a case of thalassemia major? You have to see for the profound hypochromic anemia, there is severe red cell dysplasia with erythroblastosis, and there is absence or gross reduction of the amount of hemoglobin A. There is also raised levels of hemoglobin F, that is fetal hemoglobin, and there is evidence that both the parents have thalassemia minor. Now we come to thalassemia minor. Thalassemia minor is characterized by mild anemia with microcytic hypochromic erythrocytes, that is not iron deficient, punctate basophilia with raised hemoglobin A2 fraction. There is evidence that one parent has thalassemia minor. So we have mild anemia, microcytic hypochromic erythrocytes, punctate basophilia with raised hemoglobin A2 fraction, and evidence that one parent has thalassemia minor. Now beta thalassemia, the treatment. The treatment consists of erythropoietic failure, that is allogenic bone marrow transplantation with folic acid 5 mg daily. There is iron overload, that is iron therapy is forbidden and iron chelation therapy is prescribed. And in case of splenomegaly, we prescribe splenectomy. So in beta thalassemia, the treatment is erythropoietic failure. We have allogenic bone marrow transplantation and folic acid tablets are given. In case of iron overload, iron therapy is forbidden and iron chelation therapy is given. And in case of splenomegaly, splenectomy is done. Now, what is to be done in alpha-thalassemia? In alpha-thalassemia, there is reduced or absent alpha chain synthesis. The two alpha chain loci on chromosome 16, and therefore each individual carries 4 alpha gene alleles. If one of them is deleted, there is no clinical effect. If 2 of them are deleted, there is mild hypochromic anemia. And if the 3 are deleted, the patient has hemoglobin H disease. And if all the 4 alleles are deleted, then the baby is stillborn, that is known as hydrops fetalis. This is an important term. Hemoglobin H is a beta chain tetramer that is formed from an excess of beta chains, which is functionally useless. The patient relies on their low levels of hemoglobin A for oxygen transport. The treatment of hemoglobin H disease is similar to that of beta thalassemia of intermediate severity. It involves folic acid supplementation and transfusion if required. There is avoidance of iron therapy. So this was all about thalassemia. In the next lecture, we are going to discuss about leukemia. This session is powered by Digital Version 2.0, JAYOTI VIDYAPEETH Women's University. I hope you are satisfied with my digital session. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. Thank you very much. We will be meeting in the next lecture tomorrow. Thank you.